Airway anatomy, landmarks for intubation, laryngoscope, epiglottis, cuneiform cartilage, corniculate cartilage, are epiglottic fold, vocal fold, epiglottis. Copyright Barbara Brohowski 2012. Airway management. Resistance to airflow through nasal passages accounts for approximately two-thirds of total airway resistance. Pharyngeal airway extends from posterior aspect of the nose to cricoid cartilage. Glottic opening, triangular space formed between the two vocal cords, narrowest segment of laryngeal opening in adults. Space through which one visualizes proper placement of the ETT. Trachea begins at the level of the thyroid cartilage C6 and bifurcates into the right and left main bronchi at T4, T5, approximately the sternal angle. Methods of supporting airway. Non-definitive airway, patent airway. Jaw thrust, chin lift. Oropharyngeal and nasopharyngeal airway. Back mask ventilation, LMA. Second, definitive airway, patent and protected airway. ETT, oral or nasal. Surgical airway, cricothyrotomy or tracheostomy. Methods of supporting the airway, back and mask. Advantages, indication, basic, non-invasive, readily available. LMA, advantages, indication, easy to insert, less airway trauma irritation than ETT, frees up hands versus face mask, primarily used in spontaneously ventilating patients. ETT, advantages and indication for intubation 5B, patent airway, protects against aspiration, positive pressure ventilation, pulmonary toilet suction, pharmacologic administration during hemodynamic instability. Back mask disadvantages or contraindication, risk of aspiration if decreased level of consciousness, cannot ensure airway patency, inability to deliver precise tidal volume, operator fatigue. LMA disadvantages and contraindication, risk of gastric aspiration, ppv less than 20 centimeter water needed, oropharyngeal, retropharyngeal pathology or foreign body, does not protect against laryngeal spasm or gastric aspiration. ETT disadvantages, contraindications, insertion can be difficult, muscle relaxant usually needed, most invasive, supraglottic or glottic pathology that would preclude successful intubation. Other basic and mask facilitate airway patency with jaw thrust and chin lift. Can use your oropharyngeal or nasopharyngeal airway. LMA sizing by body weight 40 to 80 kilogram size number 3, 50 to 70 kilogram size number 4, 70 kilogram to 100 kilogram size number 5. ETT auscultate to avoid endobronchial intubation. Sizing approximately male size 8 to 9, female size 7 to 8, pediatric uncuffed more than 2 years old. The age will be divided by 4 and then plus 4 centimeter. The equipment for intubation is MD zones. M stand for monitors, D stand for drugs, CS suction oxygen source, and self-inflating bag with oropharyngeal or nasopharyngeal airways. Laryngoscope, ETT, appropriate size and one size smaller. Stylet, syringe for tube cuff inflation. Tracheal intubation. Preparing for intubation. Failed attempts at intubation can make further attempts more difficult due to tissue trauma. Plan, prepare, and assess for potential difficulties. Ensure equipment is available and working. Test ETT cuff, check laryngoscope, light and suction machine check. Pre-oxygenate, denitrogenate. Patient breathe 100% oxygen for 3 to 5 minutes or for 4 to 8 vital capacity breaths. May need to suction mouth and pharynx first. Proper positioning for intubation. Align the three axes, mouth, pharynx, and larynx to allow visuality from oral cavity to glottis. Sniffing position. Flexion of the lower C spine, C5 to C6. Bow head forward and extension of upper C spine and atlanto-occipital joint. Nose in the air. Figure 6C. Contraindicated 6C. Figure 6. Anatomic considerations in laryngoscopy. A neutral position is the tongue, epiglottis, pharyngeal axis, laryngeal axis, and tracheal esophagus. This is the normal neutral position. C spine flexion position is number B. C spine flexion position, we put a pillow here. So C spine flexion is not good enough because we cannot see clearly. So we need to set up C spine flexion with atlanto-occipital extension. Nose in the air, and then we can see it clearly. Contraindicated in known or suspected C-spine fracture instability. Poor or no view of plotic opening can be remediated by anterior laryngeal pressure. Laryngoscope tip placed in the epiglottic vallecula in order to visualize the cord. Can you see here the tongue here, pharynx, vellicular, epiglottis. Vellicular is up, velliglottis, and then glottis here, and trachea and esophagus. Tube insertion. Laryngoscopy and ETT insertion can incite a significant sympathetic response via stimulation of cranial nerve number 9 and 10 due to foreign body reflex in the trachea, including tachycardia, dysrhythmia, myocardial ischemia, increased blood pressure, and coughing. A malpositioned ETT is a potential hazard for the intubated patient. If too deep, may result in right ankle bronchial intubation, which is associated with left-sided atelectasis and right-sided tension pneumothorax. If too shallow, may lead to accidental intubation, vocal cord trauma, or laryngeal paralysis as a result of pressure injury by the ETT cuff. The tip of ETT should be located at the midpoint of the trachea, at least 2 cm above the carina, and the proximal end of the cuff should be placed at least 2 cm below the vocal cords. Approximately 20 to 25 cm mark at the right corner of the mouth for men and 19 to 21 cm for women. Differential diagnosis of poor bilateral breath sounds after intubation DOPE displays ETT obstruction pneumothorax esophageal intubation. Confirmation of trachea placement of endotracheal tube. Direct visualization of ETT passing through cords. Bronchoscopic visualization of ETT in trachea. Indirect EtCO2 in exhaled gas measured by capnography, a mandatory method of confirming the ETT is in the airway. Auscultate for equal breath sounds bilaterally and absent breath sounds over epigastrium. Bilateral chest movement, condensation of water vapor in ETT visible during exhalation and no abdominal distension. Refueling of reservoir bag during exhalation. Chest X-ray rarely done. Only confirms position of the tip of the ETT and not whether the ETT is in the trachea or not. Facial intubation suspected when EtCO2 0 or nasal 0 on capnograph. Abnormal sounds during assisted ventilation, impairment of chest excursion, hypnosia diagnosis, presence of gastric contents in ETT. Breath sounds heard when auscultating over epigastrium left upper quadrant. Distension of stomach, epigastrium with ventilation. Complications during laryngoscopy and intubation, dental damage, laceration, lips, gums, tongue, pharynx, lavalvular esophagus, laryngeal trauma, esophageal and endobronchial intubation, accidental extubation, insufficient cough inflation or cough laceration results in leaking and aspiration, laryngospasm, bronchospasm, accidental extubation. Difficult airway. Difficulties with back mask ventilation, supraglottic airway, laryngoscopy, passage of ETT through the cords, infraglottic airway, and surgical airway. Algorithms exist in difficult airway. Pre-operative assessment, history of previous difficult airway, airway examination, and pre-oxygenation are important preventative measures. If difficult airway expected, consider awake intubation, intubating with bronchoscope, track lighted stylet, fiber optic laryngoscope, video laryngoscope, etc. If intubation assesses unsuccessful after induction, call for help. Ventilate with 100% oxygen with via bag and mask. Consider returning to spontaneous ventilation and or waking patient. If bag and mask ventilation inadequately, call for help. Attempt ventilation with oral airway. Consider attempt LMA, emergency invasive airway access, surgical or percutaneous airway, jet ventilation, and retrograde intubation. If you encounter difficulty with tracheal intubation, oxygenation is more important than intubation. Oxygen therapy. In general, the goal of oxygen therapy is to maintain arterial oxygen saturation more than 90%. Small decrease in saturation below uh, saturation of oxygen 90% corresponds to a large drop in PaO2. In intubated patients, oxygen is delivered via the ETT. In patients not intubated, there are many oxygen delivery systems available. The choice depends on the oxygen requirement, FiO2, and the degree in which precise control of delivery is needed. Diagnosis can be detected as SaO2 less than 85%. Frank diagnosis as at SaO2 67%. Low flow system provide oxygen at flows between 0 to 10 liters per meter. Acceptable if tidal volume 300 to 700 milliliter, respiratory rate less than 25, consistent ventilation pattern. Dilution of oxygen with room temperature result in a decrease in FiO2, an increase in an increase uh, in minute ventilation tidal volume multiply respiratory rate results in a decrease in FiO2. Nasal cannula response. Well tolerated if flow rate less than 5 to 6 liters per minute, drying of nasal mucosa at higher flows. Nasopharynx act as an anatomic reservoir of collects oxygens. Delivered oxygen concentration can be estimated by adding 4% for every additional liter of oxygen delivered. Provide FiO2 of 24 to 44% at oxygen flow rates of 1 to 6 liters per minute. Uh, HbO2 saturation curve 100%, 100%, and pH go down, increase temperature to 3 bpg. Reservoir system use a volume reservoir to accumulate oxygen during exhalation, thus increasing the amount of oxygen available for the next breath. Simple face mask covers patient's nose, mouth, and provide an additional reservoir beyond nasopharynx, fed by small bore oxygen tubing at a rate of at least 6 liters per minute to ensure that exhaled CO2 is flushed through the exhalation port and not rebreathed. Provides FiO2 of 55% at oxygen flow rate of 10 liters per minute. Non-rebreather mask, a reservoir bag, and a series of one-way valves prevent expired gases from entering the bag. During the exhalation phase, the bag accumulates with oxygen, provide FiO2 of 80% at oxygen flow rate of 10 to 15 liters per minute. Composition of air 78.1% nitrogen, 20.9% oxygen, 0.9% argon, and 0.04% carbon dioxide. High flow systems generate flows of up to 50 to 60 liters per minute, meet or exceed patient's inspiratory flow requirement, deliver consistent and predictable concentration of oxygen. Venturi masks deliver specific FiO2 by varying the size of air entrapment. Oxygen concentration determined by mass port and not the wall flow rate enables control of gas humidity. FiO2 ranges from 24 to 50%. Let's talk about ventilation. Ventilation is maintained with PPV in patient given muscle relaxants. Assisted or controlled ventilation can also be used to assist spontaneous respirations in patients not given muscle relaxants as an artificial means of supporting ventilation and oxygenation. Changes in peak pressures in AVC and tidal volume in PVCV may reflect changes in lung compliance and the airway resistance. Patient may be getting better or worse. Mechanical ventilation indications for mechanical ventilation is apnea, hypoventilation or acute respiratory acidosis, intraoperative positioning limited respiration excursion, for example, prone or Chandler-Lambert, require hyperventilation to lower ICP, deliver PEEP, uh, increased in intrathoracic pressure, for example, laparoscopic procedure. PEEP stands for positive and expiratory pressure is the positive pressure applied at the end of ventilation that helps to keep alveoli open, decreasing V per Q mismatch, used with all invasive modes of ventilation. Complication of mechanical ventilation. Airway complication, tracheal stenosis, laryngeal edema, alveolar complications, ventilator-induced lung surgery injury, bronchotrauma, volume trauma, atelectasis trauma, ventilator-associated pneumonia, nosocomial pneumonia, inflammation, auto beep, patient ventilator asynchrony, cardiovascular complications, reduced venous return secondary to increased intrathoracic pressure, reduced cardiac output, hypotension. Tracheostomy, Tracheostomy should be considered in patients who require ventilator support for a extended period of time, shown to improve patient comfort and give patients a better ability to participate in rehabilitation activities. Complication, neuromuscular complication, atrophy, increased ICP, metabolic, decreased CO2 due to hyperventilation, alkalemia with overcorrection of chronic hypercarbia, monitoring ventilatory therapy, pulse oximetry, EtCO2 concentration, regular arterial blood gases, assess tolerance regularly. Ventilator strategies. Both settings are determined based on the patient's factors, ideal body weight, compliance, resistance, and underlying reasons for mechanical ventilation. Hypoxemic respiratory failure. Ventilator provides supplemental oxygen, recruits the atelectatic lung segments, helps improve VQ mismatch, and decreases intrapulmonary shunt. Hypercapnic respiratory failure. Ventilator augments alveolar ventilation may decrease the work of breathing, allowing respiratory muscles to rest. Modes of ventilation: assist control ventilation (ACV) and volume control (VC). Every breath is delivered with a preset tidal volume and rate and minute ventilation. Extra controlled breaths can be triggered by patient effort. When no effort is detected within a specific amount of time, the ventilator will initiate the breath. Pressure control ventilation (PCV). A minimum frequency is set, and patient may trigger additional breaths above the ventilator. All breaths delivered at a preset constant inspiratory pressure. In a traditional PCV, tidal volume is not guaranteed, thus changes in compliance and resistance affect tidal volume. Synchronous intermittent mandatory ventilation (SIMV). Ventilator provides controlled breaths either at a set volume or pressure depending on whether a VC or PVC respectively. Patient can breathe spontaneously. These breaths may be pressure supported between controlled breaths. Pressure support ventilation (PSV). Patient initiates all breaths and the ventilator supports each breath with a preset inspiratory pressure, useful for weaning off ventilator. High frequency oscillatory ventilation HFOV, high breathing rate up to 900 breaths per minute in an adult, very low tidal volumes. Used commonly in neonatal and pediatric respiratory failure, occasionally used in adults when conventional mechanical ventilation is failing. Non-invasive positive pressure ventilation (NPPV) achieved without intubation by using a nasal or face mask. By BAP, increased pressure like PSV on inspiration and lower constant pressure on expiration, for example BEEP. CBAP delivers constant pressure on both inspiration and expiration. Causes of intraoperative hypoxemia: inadequately oxygen supply, breathing system disconnection, obstructed or position ETT, leaks in the anesthetic machine, loss of oxygen supply, hypoventilation, ventilation perfusion inequalities, atelectasis, pneumonia, pulmonary edema, pneumothorax, reduction in oxygen carrying capacity, anemia, carbon monoxide poisoning, methyl, um, methemoglobinemia, hemoglobinopathy, lab worship of the hemoglobin oxygen saturation curve, hypothermia, decrease 2,3 bpg, alkalosis, hypocarnia, carbon monoxide poisoning. Left to right cardiac shunt. The anesthesia circuit. Reservoir bag, unidirectional valve, respiratory limb, inspiratory limb, expiratory limb, wide piece, and a fresh air inlet, carbon dioxide absorber. Causes of abnormal and tidal CO2 level. Hypocapnia, hypocapnia, decrease CO2. Hyperventilation, hypothermia, decrease metabolic rate, decrease pulmonary blood flow, decrease cardiac output. Technical issue, incorrect placement of sample catheter, inadequate sample volume, VQ mismatch, pulmonary thromboembolism, incipient pulmonary edema, air embolism. Hypercapnia, increased CO2. Hypoventilation, malignant hyperthermia, and other hypermetabolic states. Improved pulmonary blood flow after resuscitation and hypotension. Technical issues, water in capnography device, anesthetic breathing circuit error, inadequate fresh gas flow, rebreathing, exhausted soda lamp, faulty circuit absorber valve, low bicarbonate. We complete the page A11. Next time we're gonna go over page A12, intraoperative management. Thank you and see you again. Bye bye.